very much. You're welcome.
Look at my legal pen. This is me.
I have two times.
Well, I had to go to Boston. So and again,
Oh, yeah, okay. Yeah, so we'll do 15 Yeah, and then I think that would be good. Yeah, so it's sort of in the middle.
Oh, good, okay.
Yeah, and I'll try, hopefully, I'm just waiting on one more presenter, but I'll introduce you to her.
Right, 24 state. Right, 24 state.
Yeah, yeah, I can see it pretty good. Yeah,
Is it 24 minutes of the meeting?
well, yeah, so we have,
Is it 12 minutes of presentation or 15
Yeah.
minutes of presentation?
so you get like 15 minutes total.
Right.
And then we're trying to give, about 3 minutes for Q&A, but it's up to.
Oh, no, like I timed it
So
to basically
the-
be exactly 12 minutes,
Okay.
just making sure that I like.
So there'll be nothing that's said, is it 15 minutes for both the presentation and Q&A?
Yeah, so like we don't manage the Q&A, we allow the presenters to lead their own Q&A. So we give them the 15 minutes and then.
Well,
they
so
can
as
decide.
time, if I, is it 15 minutes I should be looking at?
Yeah, all you care about is 15 minutes.
Okay, yeah,
Because it's up to the presenter, if they want to keep talking the 15 minutes and have no Q&A, then that's fine.
Oh, okay. Oh,
Yeah. It's, it's if they go too long, right? So, yeah.
Yeah. Which I have friends being super.
Yeah, I know, it's ridiculous. It's.
Also,
I know. Every time you go out, there's like different figured out.
Leave a trail of belongings behind you wherever. How did you get that? Well, thank you. Thank you for assuming I'm a competent person.
Julie. Oh, no.
Or, yes.
This is Chimdi. She'll be the timekeeper. Yeah, so she'll flash your reminder at 12 minutes in, and then a reminder at 14, and one at 15. So you get 15 total,
Okay.
and it's up to you however, you want.
Oh, okay.
Yeah, exactly, yeah. Sound okay?
That's great.
Okay, cool.
Like that, and I am, and I don't. I live in Trail of Pleasant, everything's like. Oh, it's just a shock.
Yeah, it's for this one.
It was like every cabinet in the house. There were like 10 shoes. Yes. Yeah. Oh, I've had to like train myself. This is not what you're in your cabinet.
Okay, see.
I post, yeah, I'm trying to see our. That's my kind of. Yeah, so it's like, it's a very good deep butter.
Yeah.
Now what I'll do is I'll remove a pile of butter to the meter, start with less.
Under and then, okay, then.
I bet. But I just wanted to introduce you to change.
Hi, we met yesterday.
So just look there for your time. Are you?
Yes.
Hi.
Nice to meet you.
Yeah, same thing. Yeah. Yeah, dark your eyes there for.
Thank you.
Thank you.
We have 3 minutes and 1 minute or?
There's 3 minutes, 1 minute.
Okay, great. Thank you.
For your 12:15.
Oh, that.
Okay, so which is
Your
2 minutes.
usually-
Kind of giving you the warnings to 12 minutes. I think it's like fun.
So it's 10 minutes is really you're at the end of your 12.
It's like, yeah.
Okay.
Yeah. Is
Perfect.
that-
No, it's great.
Oh, okay. is that-
Just so we know.
Yeah.
Okay.
Yeah, that's good and different.
Okay. Yeah.
Instead of, oh, I'm really far ahead, I have time.
Yeah, it's extra time.
That means monologue, it costs a little bit.
Yeah.
Got it, thank you.
Yeah.
No, the thing is like, how long could it take us? So long. It's like, yeah, I'm doing voice about.
I could as well, but if I reach the end of, of what I've actually said, and I'm in front of an audience, I can't pretend what I say. Here's one really cool ideas. What's the?
Yeah. Yeah, well, they have to email. That's quotes distributed the files onto each of the computers.
So when did you get your
Probably. Days
Of course, would not happen. Yeah.
But never mind.
it was sort
Oh,
of the
sorry. Do y'all have any updates y'all would like? Because I only have like the versions that y'all submitted.
I do, it's on a flash drive.
Okay.
So.
Do you want to load it ahead of time?
Sure.
And Allison, your version is okay?
Yeah. Thank you.
Yeah.
Ted.
All right, what's last Friday? More like I just have it. Like, they are what they are, they're in.
That was the effect of Australian walking culturally and then which is not really.
Yeah, we're.
They're the fold up for today.
Oh, okay.
You've done that for today. Yes.
I can't like get out of this.
That's fine. Everybody else is a little bit.
No, it's more like I'm trying to get out of this.
Oh, that's okay.
So I can close out the
Yeah.
USB.
Got it.
Yeah. I know there's a way to move that around.
Yeah.
There you go.
Yeah, so I can. Yeah.
Yeah, I feel like it's a. It's still a tech group for like the young people, but yeah, I'm really doing that more than
I'm presenting, because that's a group project, I think any of us get presented, we gotta do it. No, I actually was involved. The other one, I was on the advisory group.
Yeah.
50 is gonna present, but you just have her, you know. I don't. Yeah.
Yeah. No, I can base.
being professionals as well, especially for painting.
Yes.
Those people just looking at both me, just like, yeah, this. It is the best. Those kids.
Excellent.
Because people I was thinking right now.
Yeah.
They are right. They started on my street today and oh, they're. It's quite noisy.
It was interesting because people. No, we were talking about how they.
Yeah, probably.
How they can, the people they did is right.
Yeah,
Especially. The people.
Yeah.
They just want to get out of the way.
And then I walked out of the house. Looked down the street.
Yesterday, we had. And I was
day and a half period, or spring, where there was a big water. And we go rain. Live in my and rain. And I was interning at Hygiene and was right across the street. Like did not have water. Where I lived, or where I went to school, or where I worked. And in two of those locations was like, you know, branches that dedicated to safe water.
It's just 600. So
There was that was second last school. We had like for birthday, where like, you know, and water. When I was in Baltimore, there was a knowledgeable.
Yeah, I know. I'm so happy to be done.
Yeah, ours was not that cool thing. Although we did actually. Water mains. I did like seminar. That's when I feel.
Yeah, exactly.
Yeah, last December, biggest story that I was like straight up.
It gets quiet. It's hard.
We ran it. Oh, the night we turned it off and like left it with them, like ran like a bosses. It was just saying. I know, yeah, it's like a lot of. But I'm not with anyone.
Oh, 3:30.
Problem is that it's really, really happy in the sun.
Yeah.
Yeah. Yeah, we can meet upstairs and make it. I'm actually going to stay.
All right, good afternoon, everybody. Welcome to the Bellflower Room. And today the verbal presentation is on menstrual hygiene management. My name is Kevin Zhu, and I'll be the moderator for the session. And so today we'll kick it off with Julie Hennigan from the Burnet Institute. So if you all just welcome Julie to the stage, please.
Unfortunately for all of you, I'm not Brooke Yamakoshi, who is a very eloquent presenter. But I am going to present some work that we did as a collaboration between us at the Burnet Institute, WaterAid, and UNICEF to do a regional review of progress towards menstrual health in the East Asia and Pacific region. There's a big report and there's a lot to talk about, so I'm going to give you an overview and orientation to the report, some of what we did. And at the end, there's links to the report. There's a regional report, individual country reports, and a published systematic review. So I'll put all that up so you can read more at your leisure. Our review had two objectives. The first one was to document the current state of policy and programming across 19 countries in the region. And the second was to synthesize the evidence of effectiveness for policies and programs. For both, we wanted to engage stakeholders and understand what had been barriers and enablers to progress. There'd been a UNICEF report in 2016, been a landscaping and look at this. So our report was specifically looking at progress between 2016 and 2022. To achieve this, so to do our review of policy and programming, we did a desk review of policies across different sectors in 19 countries across East Asia and Pacific. And we did a survey with over 50 key informants, as well as more than 50 key informant interviews in the different countries to understand what was going on in policy and programming efforts, as well as barriers and enablers. For looking at the evidence, we also used the survey and interviews with stakeholders to understand what was going on in monitoring and unpublished evaluations. And then we also undertook a systematic review and evidence synthesis to look at the effectiveness of interventions in quantitative evaluations that had been done since 2016, knowing that there was nothing prior to that date. We had a fantastic technical advisory group who provided feedback throughout the process, as well as some stakeholder input through presentations earlier this year before the final reports came out. We had two guiding frameworks for the review. One was about what was being done for menstrual health, and the other was about how. So for the what, we use the definition of menstrual health as a framework. The 2021 definition highlighted that across contexts, there are consistent requirements for women, girls, people who menstruate to achieve menstrual health. So this includes having access to education and information about the menstrual cycle over the life course, having access to materials, facilities, and services to care for the body during menstruation, having access to care for discomforts and disorders related to the menstrual cycle, having a supportive social environment, and being free from discrimination and protection of freedom of participation. So we looked at what was happening in policy and programming according to these different requirements for supporting menstrual health. Our second framework was looking at the how. And so for this, we were looking at the sort of system or enabling environment, and we used the 5 building blocks of the Sanitation and Water for All partnership. So we looked at policies and national strategies and action documents. We looked at institutional arrangements, including coordination. We looked at funding and financing. We looked at capacity and at monitoring and evaluation and review. So this set of how considerations, you can see from the screen grab of the table of contents from the report, was sort of our guiding structure for reporting what was going on. And looking at these components also facilitated a bottleneck analysis to look at, well, for policies and plans that do exist, are they making it all the way through to service delivery? And if not, where are they getting stuck? Across all the countries in the review, we looked at government-led policies, strategies, national action plans, guidelines across sectors for sort of mention of or attention to menstrual health. Indonesia was the only country in the review that was found to have policy commitments relevant to all 5 requirements for menstrual health. That's not to say that because there was a policy addressing a requirement that it addressed everything that's required as part of that, but it does say that there's attention within that domain to menstrual health, which is in large part was huge progress since 2016. We found that the strongest policy commitments were around addressing the first 2 requirements for menstrual health. So menstrual requirements around education and information. This was largely being addressed in part through national plans for either comprehensive sexuality education or puberty education curriculum. All of the countries in the review had some attention to the second requirement around access to materials, facilities, and services for menstrual health. This was mostly through national WASH policies or guidelines, a lot of which were WASH in schools, although there were a number of countries that had examples of slight attention to menstrual health as part of WASH and healthcare facilities. Only 2 countries in the review had policies or guidelines related to materials for menstrual management. Our informants agreed that incorporating menstrual health into existing sectoral policies was a really strategic first step for them in advancing menstrual health. So this gave them a forum to start talking about the topic and a foot in the door to start getting recognition that this was important, and it opened pathways to having more conversations about other menstrual needs. In terms of institutional arrangements, responsibility for menstrual health was really mixed. In East Asia, leadership was largely coming from ministries of health and education, whereas in the Pacific, this was more assigned to those or departments who were responsible for WASH schools. Countries that were making the greatest progress were those that had clear ministerial responsibilities and coordination mechanisms. Coordination, and particularly government-led coordination, was really highlighted by stakeholders as a key pathway to improving menstrual health and to offering complementary services. I think there was a lot of emphasis that it's difficult to address one aspect of menstrual health in isolation, but that there's coordination needed across sectors to be addressing everything that's needed. We found that there was really limited documentation of funding or financing for menstrual health. Only 3 countries, Indonesia, Timor-Leste, and the Solomon Islands, had costed menstrual health lines as part of their WASH in schools infrastructure. And Fiji was the one country that had a sort of costed amount that they were dedicating towards the provision of menstrual products in schools. We didn't find any examples of line items or costing for menstrual health provision of education or in health sector budgets. Few countries had explicit policy milestones that could actually be costed against, which was another key finding. So this sort of prevented budget from being allocated because it wasn't a discrete line item or commitment. Drawing together these different building blocks, the report has a number of tables, of which this is an example, that tracks the policies and plans that we identified through the chain to identify where there are weaknesses, perhaps in implementation arrangements, budgeting, through to service delivery. Very few policies or programs were being monitored. The only policies with menstrual health related indicators attached to them were WASH in schools policies, and even fewer of those had menstrual health specific indicators. Most of them were sort of related proxies, like having sex segregated infrastructure in schools. I didn't really get time to talk about programming. I focused on policy given the restricted timeline for this presentation. But stakeholders consistently highlighted that monitoring was a really important gap. Some of the challenges for monitoring included not having clear responsibilities for monitoring, capacity gaps, budgets, and not having indicators embedded within national systems. We often heard that both at the national level and also in terms of non-governmental program monitoring, that because menstrual health activities were a small component of a broader WASH or sexual and reproductive health intervention, that they were falling through the gaps. So even though menstrual health was a component of these, there wasn't specific indicators for them, or it didn't feature prominently within the theory of change. And so it wasn't being monitored from the start. This meant that even if it turned out that menstrual health was a really core component to the WASH in schools program, that because there weren't indicators built in, it wasn't being monitored, and it was really difficult to reverse engineer this later. Our systematic review of evidence would take a whole separate presentation to share in detail. But we certainly found that from having no evaluations in 2016, that there was more research happening to 2022. What we found is that the study quality was really limited, and that there was definitely insufficient evidence for the effectiveness of any menstrual health interventions in the region, including our extension to include supports for referral for discomforts and disorders. I think most importantly, in the interest of keeping this short and not diving into details, the interventions that were being tested in research did not reflect the current policy or programming initiatives or the things that were being looked at in programming and policy. And at the same time, programming and policy weren't being evaluated. So there was this real mismatch between the types of things that were started to being investigated in evaluations and research and what was actually going on in practice. There's a huge number of takeaways that we've outlined in the report. I think some of those include that advocacy and in countries where there is less momentum and less action happening around menstrual health, some of the enablers that were identified for countries that have made much more progress in giving attention to this issue can be a sort of roadmap for advocacy in countries that are earlier in the process around getting started. There's a real need to attend to what we call neglected requirements for menstrual health. So actually addressing the supportive social environment and pathways to care for discomforts and disorders. I think often within education or WASH, we're like, yeah, people are in pain during menstruation, we'll refer them to the health services, but then there's no adolescent-friendly health services to refer adolescents to, or adult women. We really need evidence that actually matches the priorities of policies and programming, and the programs that are being implemented need to be evaluated. So I think stronger partnerships between implementing organizations and researchers could be a pathway to addressing some of that. There's a need to strengthen capacity, both for enacting menstrual health service delivery, for providing coordination, and for monitoring. Particularly to make sure that menstrual health components aren't lost, where they are embedded as a smaller aspect of a WASH or an SRH policy or initiative. And there's a need for greater government-led coordination to reduce duplication and gaps. There are some examples in specific countries where there were technical groups or other networks that had been set up that stakeholders identified as opportunities to leverage and to involve more government coordination in the country. So these are the links to the full report, the regional report, the country reports, and the systematic review, which has been published separately. And happy to take any questions in the remaining 2 minutes that we've got.
Any questions?
And one of the questions you mentioned that is the need for the government to buy in and actually do a crossover there. There's lessons learned. How do we translate that in action for those that don't quite have that push yet? Is the next step of your reporting or pushing that? Because that seems like a key driver of this.
The financing component?
Yeah.
Yeah. Yes. I mean, I think one of the things that was identified as part of looking at that was this absence of milestones or particular lines for menstrual health that could actually be costed. Because if you're going to have a budget line, you actually need to have a milestone that matches. So I think some specific pushing on ensuring that we have specific objectives around menstrual health or hygiene, not just we have a WASH policy and it should pay attention to menstrual hygiene, but we don't really hold anyone accountable to any indicators or monitoring or specific milestones for that, as well as that obviously actual budget commitment. I mean, I think it could be budgeted within those broader policies, but when it's not being prioritized within them, then it's a challenge. There was a lot of tension in stakeholder feedback between, well, we should have a standalone policy to coordinate across the region to get more prioritization of menstrual health versus funding is sectoral. There's different government ministries that are responsible, and this is a really sensible pathway into addressing this issue. Yeah.
The time, sorry.
Yes, you've got 1 minute.
I was wondering if there was any discussion around social norms that inhibit, some of the work, particularly in these countries. Contextual norms can really inhibit any kind of action, whether it's policies, whether it's programs, or anything happening at individual level.
Yeah, I mean, throughout in terms of identifying barriers, the stigma around menstruation and even policymaker willingness and government willingness to talk about it was definitely a barrier in some countries. As I think you saw, support for the social environment, which is that social norms piece, definitely wasn't there in policy or programming. I think I could talk forever about what I think, things I think we should be thinking more about and how we need to be bringing a lot more thinking to how we can actually effectively address that social component. Great, thanks.
Or
Okay.
I'll do it.
The next presentation is from Vishna. Fortunately, you're not going to have to listen to my voice again. Unfortunately, Vishna wasn't able to be here, but she has recorded her presentation. And so I'm gonna press play on that and let you listen to her. I will do my best to answer any questions that you have at the end, or otherwise I'm just gonna redirect you back to her.
My name is Vishna Shah, and I'm going to talk to you about the MEGAMBO study, which is a multi-component menstrual health intervention in rural Gambia. In recent years, menstrual health has received more attention, and it's highlighting the challenges faced by adolescents. However, there is a lack of evidence to inform effective, cost-effective, and sustainable interventions to mitigate adverse educational, health, and social effects. Data from Gambia suggests there is a decline in school attendance as girls move to secondary schools. Informative research conducted by the team suggested that about a quarter of girls reported missing at least one day of school due to their last period. The aim of the study was to assess whether a multi-component menstrual health intervention addressing physical and social aspects of menstruation improves school attendance, health outcomes, menstrual-related well-being, social support, and menstrual health knowledge, attitudes, and practices amongst target schoolgirls in rural Gambia. A randomized controlled trial was conducted in 50 clusters from 2 regions in the Gambia. That's the North Bank and the Lower River region, which are underlined in red on the map here. Half of the clusters were intervention and the other half were control. Target sample size at the end-line survey was about an average of 75 girls per school. And in the end, we were able to sample a total of 3,664 girls. Selection of the clusters and training of trainers for the intervention delivery started in August 2019. The full intervention was delivered to the 25 schools, to the 25 intervention clusters between October and December 2019. The online survey was conducted from January to March 2020. And the online data collection was completed in 45 schools before the COVID-19 related school closures. And then data collection resumed again in October 2020, a month after the schools reopened. The intervention package had 4 aspects to it. The mother's outreach targeted mothers who had adolescent girls in the school to improve their knowledge about menstrual health and raise awareness of the importance of discussing menstruation with their children. The peer health sessions targeted schoolgirls and boys. This aimed to improve knowledge, awareness, and break taboos. And a subset of the students were also trained to be ambassadors and share menstrual health information with others in the school and community. The school wash improvements were tailored to each school depending on their needs. We worked with the schools to improve water availability around the toilets, having hand washing stations with soap and water near the toilets, as well as ways to improve privacy and cleanliness of the toilets. Community meetings were open to all, but held specifically to try and engage the men in community about menstruation and to try break stigmas and taboos. And all sessions were designed to be dynamic, participatory, and included role play. All villages in the 2 regions that had schools with grade 7 and upwards were listed. From this, 50 villages were randomly selected. 1 school per village was selected. In villages that had more than 1 eligible school, the largest school was selected. This resulted in an odd number of schools of each type. Therefore, 1 English school was substituted for 1 Arabic school in a village that had both of a similar size. Restrictive randomization was used to allocate the villages to control and intervention groups. All girls that were 13 years and older and had started menstruating were included for the online survey, and we used the intention to treat approach. The primary outcome was the percentage of girls who missed at least 1 day of school due to her last menstrual period. Other secondary outcomes included number of days missed in the last 30 days due to menstruation, urogenital symptoms, biochemical markers of UTI, menstrual-associated well-being, social support, and knowledge, attitudes, and practices towards menstrual health. I'll now discuss the results of the study. So the socioeconomic indicators were similar across the control and intervention students. In the graphs shown here, the blue bars with the dotted lines represent the control arm, and the red bars with the solid lines represent the intervention arm. Majority of the students walked to school, and they had parents who had either no formal schooling or Arabic schooling only. Access to water was mainly through community standpipes, and all had access to some form of household toilet facilities. And for most, this was a pit latrine with a slab. Self-reported school absenteeism of at least 1 day during the last period was only slightly lower in the intervention arm than the control arm. As you can see, it was 17.1% versus 15.6% with a p-value of 0.4. The lack of intervention effect was not affected by excluding the schools where data was collected after the pause due to school closures. Averagely, girls missed about half a day of school per month due to menstruation, and this ranged from 0 to 10 days, and there was no difference between arms. The prevalence of reported urogenital symptoms was high and similar among control and intervention school girls. The most reported UTI symptom was bad smell, followed by feeling of burning when urinating. The intervention had positive effects on menstrual-associated well-being, and this was calculated using 10 questions. Exploratory factor analysis suggested the presence of 2 factors, one related to happy or comfort, and then the other related to worried or stress. Positive results were seen on individual factors as well, such as happy to continue usual activities, using school toilets, using their menstrual absorbents, participating in school, and overall being happy while menstruating in school. However, there was no difference seen in factors such as worried about the amount of water in the school toilets, staining uniform, and worried other people will know they are menstruating. Schoolgirls in the intervention arm reported higher social support than their peers in the control schools. We could also observe positive effects on attitudes towards discussing menstruation with mothers, caregivers, and teachers in the school, although there was no effect seen on the fear of teasing or being prepared for menstruation. There was positive results across menstrual knowledge, attitudes, and practices. The most notable changes were in understanding menstruation was not a disease and knowing the duration of the menstrual cycle, which allowed them to track their cycle better. Attitudes and perceptions strongly affected by the intervention included they don't believe that disposable pads cause disease and thinking it's acceptable to cook while menstruating. Key practices promoted in the training was drying reusable material in the bathroom with no roof or outside in the sun, and this increased in the intervention arms by 13 percentage points. There was no impact on attendance due to menstruation or on the health outcomes. However, there were broad positive effects on menstrual health knowledge, experiences, and needs. There are several reasons why no impact on attendance was seen. It could be that the intervention activities were insufficient to change other intermediate outcomes that could translate to higher impacts, or increased frequency of the intervention was needed. Although the intervention discussed pain management, we did not give out any painkillers, and during the survey, girls still reported experiencing menstrual pain. Additionally, it could have been that there was lack of sufficient absorbent materials. The intervention did not provide any absorbents, as the government had a scheme to provide disposable sanitary pads to public schools. However, during evaluation, we did find that there wasn't always a supply in the school, or it wasn't always accessible to the girls. It could be that the girls exposed to the intervention were more likely to pay attention to menstrual-related absence and remember when they missed school. Also, the last 30 days may have been a harder recall period, but also a longer recall period, such as term, could have its own set of challenges. Biases could have been introduced by girls being absent from school due to menstruation at the time of outcome assessment and not being included in the estimate. Girls may not have reported absence due to social desirability. Girls reported having increased discussions about menstruation with mothers, female caregivers, or teachers, and being more comfortable to do so. This was a key target of the intervention and done through multiple channels. Boys were happy to be a part of the discussion and wanted to know more, so they were better able to support the girls around them. However, we were only able to target a subset of boys. It may be worth having more sessions dedicated to the boys to sensitize them more, and this may help with the issue of teasing, as this was still an aspect that girls felt worried about. The sessions were engaging, interactive, and had aspects of demonstrations, such as how to use menstrual absorbents and role plays on how to talk about menstruation with others. This created open, honest, and memorable discussions, which could have accounted for the positive impacts. Girls were more comfortable using their absorbent materials. This could be due to the demonstrations mentioned, as well as information to dispel myths about different absorbent materials. Although attendance didn't change, girls in the intervention arm had higher reports of being happy to be at the school while menstruating than those in the control arm. No difference was seen in reports about being prepared for menarche, and this could be because too few girls reached menarche between the training and the evaluation. No impact was seen on urogenital health impacts, and this could be because it needed more time or more robust clinical diagnosis, or other factors could be that the girls did not have enough access to absorbent materials, so didn't change their materials frequently enough. Or that they were still not comfortable using the school facilities, so they may not have been urinating or changing their materials as frequently. The schools reported challenges in the wash aspects in terms of ensuring that there's always water near the toilets, as well as taking the water to the toilet. So we need to explore better methods of doing this. The girls were also still afraid of staining their uniforms. This could be due to access to absorbent materials, and we need to explore better ways of having access to the materials. Or another factor could be that if they had stained themselves before, then this fear is a bit more deeply ingrained and harder to break out and requires more sensitization. To reflect on the study so far, we found that the interactive engaging session with the use of demonstrations and role plays was effective. We need to explore better ways of measuring school attendance. Additionally, it's worth considering moving away from attendance as a key measure and using other measures instead, such as concentration, performance, self-esteem, or well-being. Sustainable and effective safe pain management strategies need to be considered, as pain was still highly reported by the girls. The intervention package requires more frequency or repetition of sessions. And lastly, more involvement of the teachers and higher frequency of initial training of the teachers is needed to ensure that they're comfortable discussing this topic and could increase sustainability of the program. I'd like to thank everyone involved in this study. And to thank you to everyone here. I am open to questions and discussing this further, and here are my contact details.
I can't promise to be able to answer your questions, but if there are questions, yeah. No.
Okay, I don't know if you can help me understand this, but I was curious when I saw the COVID happening in the middle of the inline surveys. Was there any practice of like validating the results of the inline surveys before COVID with the after COVID absence? Because I would assume the girls' access to services would be a lot different at home than at school, and I'm just curious if we would see that.
Yeah, so I can tell you that, and I think Vishna mentioned it during her presentation, that all of the primary analysis had sensitivity analysis that looked just at the schools who were surveyed prior to COVID, and that there was attention to that in the analysis. And I know that they did, and I think Vishna mentioned it in one that lack of results on absenteeism during menstruation wasn't changed, whether or not they included the couple of schools that they had to go back to after the break for COVID.
So apologies that I came in late, but fantastic to see that, and also the sort of move away from attendance, which I know you've been on appreciate. The last menstrual period recall, I just ponder that one all the time for all studies in terms of what girls actually, because I could never remember mine. So I just wondered, do you have any thoughts on that assessment measure itself in general?
I can't answer for Vishna or Villain, but from my own perspective, I think that there's not a more appropriate recall period, and I think it varies the extent to which girls are able to accurately recall the timing of their last period. I think it primes recency if it's not specifically the last period. Did they look at that a little bit in meniscus and some of the formative work, the concordance between girls' diary entries and reporting on the last menstrual? Yeah, I mean, we are gonna look at it in one of the things that we're doing. But yeah, I think it needs a little bit more work for validation, but I also think that there's not an immediate low-hanging alternative.
Thank you.
Great. Thank you, Vishna and team.
Good afternoon. I'm Madeleine Patrick. I'm with Emory University, and I'm going to be talking today about knowledge, attitudes, and support of women's menstrual experiences among men in Kampala, Uganda. So for a little bit of background, men's knowledge of menstruation, men's knowledge of women's menstrual experiences, and men's roles in creating supportive environments for women's menstruation has largely been unexamined. There is some research on men's knowledge. It tends to come from high income settings. We do know that boys often lack education and knowledge about menstruation because it's often not formally taught in schools. Boys are also frequently excluded from discussions that may happen at home or may happen informally. And a lot of these school programs that do talk about menstruation talk about it from the context of puberty or sexual and reproductive health, and not WASH or the actual experience of women and girls. There is, however, a growing interest in engaging boys in menstruation-related education, largely through school-based interventions. But these interventions tend to be fairly local or regional, and they often are not enshrined or budgeted for in national policy. And also, they aren't open to men. So while those boys will grow into men, the existing pool of men do not have access to this education. But we do know that men play an important role in decision-making around sanitation and around household finances, and these can both affect women and girls' experience of menstruation. So to that end, the study has a few aims, the first of which is to assess men's knowledge of the menstrual experiences of women and girls, to evaluate their support for menstruating women in their households, and to identify normative perspectives on menstruation. I'm going to be presenting largely descriptive data today, but analyses are ongoing on this data. So this data comes from the larger MUSE study, or Measuring Urban Sanitation and Empowerment. The goal of that study was to create and validate scales to measure the relationship between women's empowerment and sanitation. Sheila Cineroy is going to be presenting on that on Thursday, so I'll take that opportunity to plug that work. The full survey was deployed to women in 8 cities recruited at the household level. You can see them on the map there. With the little green outline, we had a modified survey deployed to men in 2 cities, Kampala and Warangal, India. And this was based on fairly broad interest from not only us, the study team, but also our partners and our funder. And then our original plan was to delete items on menstruation from the survey that we gave to men, but our local partner, Kampala Capital City Authority, really pushed for the inclusion of menstruation items. They were interested in the data And they also thought it was really important to normalize talking to men about menstruation and not treating it as a women's only interest. They did not want to perpetuate norms of keeping men apart from these discussions. So in Kampala, while we collected data from men and women across all 5 districts, we collected data from men in 7 zones within 3 districts. So the survey instruments for the Muse study were based on this conceptual framework of empowerment. There are independent scales for each subdomain. And the subdomains that have the star next to them are the subdomains where we identified menstruation-related questions that could be delivered or adapted for a male audience or participant pool. To give you an idea of some of these adaptations, there were items that remained the same for women and men. These items were particularly around norms. So it is appropriate for women to discuss menstruation-related issues publicly. There were no changes there. Some items were adapted. So women were asked, when I face a problem related to menstruation in my sanitation location, I can freely talk about it. Men were asked, when women in my household face a problem related to menstruation, they can freely talk about it. And then there were items that were added all together in order to get at individual men's support, such as women in my family can freely talk about problems with me. This is our respondent pool. We had a total of 641 in these neighborhoods where men and women were surveyed. I'm only looking at women's data from those neighborhoods where men were also surveyed. As I said just a minute ago, items about norms were asked of everybody. We had items on specific experiences or practice that were asked of menstruating women or men with menstruating women or girls in their household. So if you see MWG on slides, which you will, because menstruating women and girls is a lengthy statement, a lengthy phrase, that's what that means. And then to try to increase respondent comfort talking about this and hopefully reduce some risk of social desirability bias, we did have gender-specific enumerators. So men were talking to men about menstruation and women were talking to women about menstruation. So first, let's talk about women's practices and men's knowledge of their practices. I do want to briefly note that the men and women's data were not collected from the same household. We had a lot of trouble actually collecting household dyads. But these are population estimates of men and population estimates of women. But demographically, the women and the men matched fairly well. And we did collect representative random samples within the target neighborhoods. So we would expect similar responses. So first for materials. These were asked about all materials used and it was multiple response. But at least 15% of women were using some kind of reusable sanitary pad or cloth. Again, the cloth could be, those 19 could be included in those 27. So I don't want to add those together. So we have at least 15% using a reusable or non-disposable option, but when men were asked about materials women in their household use, they only 4% said that reusable or non-disposable options were used. We also asked about how these materials were disposed of. Men are also understanding the extent to which women do not dispose. This makes a lot of sense considering they're underestimating the use of non-disposable options. They are also vastly underestimating the extent to which women are actually flushing their menstrual materials or putting them in pit latrines. A fifth of women are flushing their materials or putting them in pits. Men are estimating this at only 3%. Now, moving out of practices and into norms, we had a series of questions about norms. This particular question is related to discussing menstruation in family discussion. So the full question is, in this community, it is appropriate for women to express menstruation-related concerns when her family is making decisions related to the sanitation location. These are percentages of those who agreed or strongly agreed with this statement. The blue is men with menstruating women and girls in their family, the yellow is men without menstruating women and girls in their family, and the magenta is women. You can see that by and large, most people agree that women can talk about menstruation related to sanitation with their families. However, this is capturing their perception of a community norm. So in our relation scale, we also wanted to capture if the individual being asked, the man, was personally supportive. So when we asked that of men with menstruating women or girls in their family, we found that 71% state that women in their family can freely discuss menstruation with them. This is pretty good. It is worth noting that there's about 6.5% of men who say it's appropriate for women to talk about menstruation with their family, but please not with me. And since this item on norms is specifically about making this item on norms is specifically about making decisions related to the sanitation location, we also wanted to capture men's comfort with participating in these decisions. And we found that 83% of men with women and girls in their households are comfortable expressing their opinions on menstruation-related sanitation issues and household discussions. Which is also a little interesting because this means there are about 5.5% of men who say women should not be discussing menstruation in their families, but I'm happy to give you my opinion. So then getting into more less outside of just a private family environment, we had an item that asked about how appropriate it is for women to discuss menstruation in front of men. Once again, you can see the group that perceives the most supportive norms is men with menstruating women or girls in their household. The group least likely to agree with this is women. In fact, men with menstruating women or girls in their household are almost twice as likely as women to report that this type of discussion is appropriate. And lastly, we also captured norms related to public discussion of menstruation. This is the first item where a majority of all three groups disagree that it is acceptable for women to discuss menstruation. However, there are still some fairly large differences in percentages, particularly between men with and without menstruating women or girls in their households. So we wanted to investigate that a little more. These questions were asked around a Likert degree of agreement scale, ranked 1, 2, 3, or 4. And we did find just doing a really simple, one-way ANOVA, statistically significant difference in the degree of supportive norms for public discussion of menstruation between men with and without menstruating women or girls in their household. And then finally, I just want to briefly highlight all three of these norms questions together so you can very clearly see how as you go from private discussion to more public discussion, people perceive vastly less supportive norms around discussing menstruation. So as far as next steps, these are very preliminary analyses. We have not looked yet at variables such as how age, education, religion, or ethnicity may be influencing these norms. We do plan to test those models. We did find here that discrepancies between men's knowledge of women's menstruation practices and women's actual practices, particularly around the use of cloth or non-disposables and method of disposals, those are pretty big discrepancies. Which is interesting because non-disposable options such as cloth, require a lot more care, including washing and drying these materials, and this has gone unnoticed by men. So women may be taking steps to hide washing and drying, and if these cloths aren't washed and then fully dried, ideally in the sun, there are actual health implications for women. So it's worth investigating if these materials are being adequately cared for, even if these behaviors are going unnoticed. It's also worth investigating reasons for why there's such high rates of disposal in pits or flush toilets. If it's that there aren't rubbish bins available or that those bins don't have lids, women may have privacy concerns with people seeing their used menstrual materials. And if this is also the case, then a menstrual stigma or a lack of a supportive sanitation environment has actual implications for sanitation infrastructure. And then women are more likely to perceive restrictive norms around discussing menstruation than men are. But generally men with menstruating women or girls in the household are supportive, particularly for private discourse around menstruation. So there are opportunities here to leverage some of these relatively supportive norms and engage men to be better allies, as well as a broader need to improve norms around public discourse regarding menstruation. So I'd like to thank KCCA, who really prodded this into existence, and Athena, CME Solutions, and of course our funders, the Bill and Melinda Gates Foundation. Are there any questions?
Sorry, I'm trying to.
I can also project. Thank you so much, Madeline. That was great. So among the men, was there like a disaggregation of like men that are married or men that are in like domestic partnership or men that have female children versus male children, like men with menstruating women, girls in their house? So how is that branched out? And was there an analysis of the impact of
We
that?
haven't done the analysis yet. We can. I did look at what that is, and it turns out there was a really, really big overlap between men that are married or living with a female partner and men that have a menstruating women and girl in the household. So I ended up just focusing on that because they might be learning about menstruation because they have a wife or partner, but also they could have a daughter, and we don't actually have son or daughter information.
Gotcha.
As far as children in their household.
Makes sense.
So, yeah.
Yeah, thank you. Very interesting presentation. I think it would be cool to go back to the people that you surveyed and show them the results and see how they might rationalize it. And that might also bring us some interesting results. So my question is, you mentioned that you weren't able, or you had a lot of trouble finding dyads, and that would have added a lot of validity to your results. So can you explain why? I mean, I couldn't think of an obvious reason why it would be difficult. So could you just explain why you had that trouble?
Yeah, so for the larger study, our focus was women. So we were first recruiting women in households. And then there were difficulties scheduling with men when they were home and available, and the data collection team was also working. But also there were a lot of women that did not want us to talk to men in their households, either because they didn't want men to know that they had received a relatively small, but still a compensation for doing the survey. And there were women that didn't want men to get a compensation for doing the survey because they were concerned that they would go and just drink the next day instead of work or focus on the family. So yeah, that's why we were not able to get household dyads. I think in the entire, of the data I presented, actually, I guess there are 8 people from household dyads.
And do the dyads confirm the rest of your findings?
With 8, I don't know. 4 women and 4 men, like I don't, yeah, I wouldn't be able to say that with any certainty there. Yeah.
Oh, well, great presentation. Two questions. It was so enumerators were men talking to men. How can you go into just the training of those individuals, how that went and how successful was that discussion to get them to then work on discussing with other men? Just be, curious on that. And then the other one, what would you expect if we were to do this in high income countries?
Honestly, I'm not sure. There has been more research in high income countries, especially around college aged men, around their understanding of knowledge of menstruation. It's still not great. But the research is there a little more often. In terms of, sorry, can you repeat the first bit of your question?
So it was equal discussions. So training the men to have these discussions with other men.
Yeah, honestly, it might be just a credit to CME Solutions, who were the data collection firm that was contracted with there, but the men among the enumerator pool were great. They didn't seem to have any shyness about this. They were happy to talk about it. And a lot of the research that does exist, like with boys, for example, has shown that men and boys are often curious about this and feel like they can't talk about it. So
yeah, like, do they have to say, hey, these are the questions you should ask, that kind of feedback mechanism? I was curious, so was it set up before and then later?
It was set up before. The questions, since they were modified off of women's questions, which had already been validated with cognitive interviews and all of that, we didn't feel like we could change too much. But yeah,
Great, thanks.
Thank you. Oh, no more time. Okay. One more. Okay.
Thank you for the presentation. This is so cool to see that this is being studied. I was curious if you had, before you started, or maybe even after, any idea of where you can see this being used, maybe in policy, advocacy. This kind of research is so unique, and I was curious if you had any thoughts on how it could maybe be used in an application.
Great question. Might put that to other practitioners in the room if anyone has any ideas. But I do think getting back to the point I was making in the introduction, you know, there is an increasing amount of work being done in terms of engaging boys. It is a little harder to engage men just because we don't get them in schools where they're in a classroom and sort of have to listen. But I do think it is important that when men are being engaged in questions about, say, sanitation, infrastructure, whatever, that questions about menstruation are being asked, if nothing else, to force them to think about it and to perceive that, okay, other people's experiences are different. Women specifically, their experiences are different than mine. But other than that, I don't know. I'm still looking more into that. I'll let you know if I come up with anything. And I welcome ideas from everyone. My contact information is up there. So, thank you.
All right, please welcome Allison Salinger from Emory University.
Hey, how are we doing? Last one. Good, okay. I'm Allison. I'll be presenting on the validation of the Menstrual Practice Needs Scale for the workplace, or the MPNS-W, and associations between MPNS-W scores and well-being indicators. So impacts of negative menstruation experiences and unmet needs include consequences for both physical and mental health, and limited ability to participate in education and employment. But much of this research has been focused on adolescent school-aged girls, and funding for programming and measurement development has as well. Adult women, by comparison, are understudied, especially those who have to manage their menstruation in the workplace. But this is a really important population because unmet needs in this population can negatively impact women's earnings and advancement opportunities in the short term, and act as barriers to women's economic empowerment and gender equality in the long term. So the original Menstrual Practice Needs Scale was created by Julie Hennigan and her team, who you heard from today, based on a systematic review and meta-synthesis. It was initially validated among adolescent school-aged girls in Uganda, and then subsequently revalidated among adult working women in Uganda. So this version of the tool includes references to both the home and work environment. Our team adapted this tool to focus exclusively on the workplace, and then this study is a validation of that adaptation of the tool among women in Kenya and Nepal, which are two new country contexts for validating this tool as well. So women in our study were at least 18 years of age and had had their menstrual period while working specifically outside of the home for payment of some kind in the last 3 months in Kenya or 6 months in Nepal. The window is a little bit longer in Nepal to accommodate COVID restrictions at the time. So in order to move from the MPNS to the MPNS-W, we consulted subject matter experts, conducted cognitive interviews, and piloted the tool as part of a larger survey. We then administered that survey, and using responses from the MPNS-W, validated the tool using exploratory and confirmatory factor analysis, and then conducted tests of measurement invariance to assess that the tool was equivalent between Kenya and Nepal, and then assessed internal consistency or reliability of the tool. Once we had the finalized MPNS-W scale, we were able to calculate scale scores and look at relationships with well-being indicators. This also allowed us to confirm construct validity because those well-being indicators were selected a priori as hypothesized correlates of menstrual experience. So that's a lot, but I'm just going to focus today on results from the factor analyses and associations with well-being indicators, but I'm happy to take questions on other parts later on. To zoom in on the tool a little bit, as I mentioned, the MPNS-W refers exclusively to the workplace environment. So the tool is framed around your last menstrual period you had while working outside the home. So an example item is, were the materials you used to absorb or catch menstrual blood comfortable? As with the original tool, all of the items have response options, never, less than half the time, more than half the time, always, and positively oriented questions like the one on the left side of the screen are scored 0 to 3 from never to always, and negatively oriented questions are reverse coded so that the higher scores reflect more positive menstruation experiences. Total scores and subscale scores, as with the original tool, are simple means for the relevant items. So what am I talking about when I mention these well-being indicators? First, we looked at wealth, which was assessed looking at household ownership of assets. We calculated a wealth quintile, and we're looking specifically at associations between women's menstrual experiences and their likelihood of being in the highest wealth quintile. The hypothesis there is that women who are wealthier might have more access to resources to enable more positive menstrual experiences. Psychological well-being was measured using the WHO-5 well-being scale, and positive well-being is considered a score of 13 or above out of 25 on that scale. Work absenteeism, these were women who said that they did not miss a partial day of work nor a full day of work due to their last menstrual period. And then menstruation-related self-efficacy was classified as women saying they were completely confident managing their menstruation in the workplace. So out of our total 892 women, we did achieve a nice variety of job type, which we're really excited about because we think that it has positive implications for the generalizability of the tool. However, most of our women were pretty urban and relatively highly educated, with almost 70% achieving above a secondary level of education. The vast majority, upwards of 90%, used disposable sanitary pads and changed those pads mostly in a facility or toilet at the workplace, although a large minority in Kenya had to use a public or shared toilet outside the workplace. So I'm going to step back and explain you through this slide a little bit. So factor analysis is used to assess hypothesized relationships between observed variables and underlying latent constructs. So in this case, the observed variables are women's responses to the individual MPNS-W items. So by looking at the items' variances, or how they sort of hang or group together, we were able to identify 4 subgroupings or factors of those items. So the factors that emerged were menstrual material satisfaction and access, disposal and changing environment. So those were questions like, how satisfied were you with the cleanliness of the place where you changed your menstrual materials at the workplace? Were you worried about people seeing you or harming you while you were changing your menstrual materials at the workplace? Transport and storage. So these were questions about level of comfort carrying menstrual materials to work or to the place where you changed or disposed at the workplace. And then finally, menstrual material reliability. So these were questions about whether you were worried about your menstrual materials leaking or moving from place while you were wearing them at work. So our exploratory and confirmatory factor analysis showed us that all items had strong and significant factor loadings, and each of the 4 factors, as we hypothesized, is significantly correlated with each other factor, i.e., we have a valid tool. So in order to get our total score, we take a mean of all the 19 items across the top of the screen there. I won't get into patterns in subscale scores today, but I'm happy to take questions about those. And we did also, calculate the sort of subscale scores as well. In this slide, we have categorized those total scores such that women with a total mean score, for example, between 2 and 3, are classified as having their needs met more than half the time. So we're just categorizing that mean score. So women in our sample had a relatively high total MPNS-W score, with about 90% having their needs met always in the green or more than half the time in the yellow. In this slide, we're looking at the distribution of those well-being indicators within the MPNS-W score categorization. So for example, this 20% here in highest wealth quintile means that 20% of these women who had their needs met always fell within the highest wealth quintile. So if we look across, we can see generally the more menstrual needs were met, the more likely women were to fall within the highest wealth quintile, to have positive psychological well-being, that score 13 or above on the WHO5, did not miss work due to their last menstrual period, and were completely confident managing menstruation in the workplace. We also ran some binary logistic regression models to look at these relationships a little more quantitatively. And we see that for every 1 point increase in total MPNS-W score, the odds of being in the highest wealth quintile were 2 times greater. The odds of having positive well-being and the odds of not missing work due to your last menstrual period were 3 times greater. And finally, the odds of being completely confident managing menstruation in the workplace were 9 times greater. So overall, we can see that meeting the needs of menstruating women in the workplace is critical and strongly associated with psychological well-being, work absenteeism, and confidence managing menstruation in the workplace. We also can see that menstrual experiences are multidimensional. We know this because even when we narrow our focus to the workplace environment only, we're still getting a 4-factor solution with 4 distinct sort of subgroups that each capture a different aspect of the menstrual experience. This necessitates programs that address and tools that measure the full scope of menstrual needs and experiences. Menstrual experiences are also interconnected. As we saw, each of those 4 factors was significantly correlated with every other factor in the scale. So we need to move beyond singular or overly simplistic indicators or facilities checklists. For example, if we have a program that provides disposable sanitary pads, and then we ask women, are you satisfied with your access to menstrual materials? We're completely ignoring the fact that supplying disposable sanitary pads changes their experience of changing and disposing, right? The MPNS-W is valid and reliable, yay! If you don't believe me from the slides, keep right up to the paper. Thank you. Generalizable question mark. So that's where you come in. Job type, as I mentioned, we did achieve a nice variety of job type, but our women are pretty urban and very, very few of them use reusable menstrual materials. So we would highly encourage others who are interested in using the tool to revalidate it in rural contexts, in contexts where reusable menstrual materials are more common. We would advise doing some qualitative formative work first, maybe with some focus group discussions or cognitive interviews to ensure that you're capturing the full breadth of menstrual experience as it applies to that other context that we weren't able to validate. Finally, the MPNS-W is practical and powerful. Total scores were powerful predictors of well-being outcomes, as we saw. And while we wouldn't advise using subscale scores in isolation, they can be examined relative to one another to identify areas of greatest need. And I'd like to thank everybody who made this happen and take your questions.
Hello, I'm Chris from Splash. That was awesome. I love the presentation and the link between well-being and the needs scale. I'm curious, I know you have income as one of your well-being measures, but when controlling for income, did you still see a 3x change in like psychological well-being? So did you use any covariates when looking at those relationships at all?
Right. Yeah. Thanks for your question. We didn't model sort of strong predictive capacity. This was all that data was from a cross-sectional survey. So I think it would be really interesting to look at a research question like that with data that has a little bit more temporality and directionality to it. But that's a great question and something that I'll definitely consider looking at the data for. Thanks.
I have another question. I'm curious, in other related work, has comparing the needs score to well-being measures been like pretty well established? And that's just my own ignorance on the topic. And to what extent has that been pretty clearly demonstrated?
Yes, I know I selected these well-being indicators based on Julie's revalidation of the MPNS in adult working women. And these results are pretty consistent with what Julie found in that population in Uganda as well.
Which was adjusted for income.
It was.
There you go.
But I can't remember the exact effect size, but that's the only two studies that I'm aware of that have looked at the scale and psychological well-being. It's also been found among adolescents.
This paper. Sorry.
Christy from World Vision, thank you for your sharing the results. I may have missed this, so I'm curious if there's any differentiation between the types of work women did, the types of jobs they had, and if you looked at the informal types of jobs outside the home as well, field work.
Yeah, thanks. Yeah, so women were randomly sampled from their neighborhoods. So neighborhoods were purposefully selected to maximize variation in socioeconomic status and like work sector. But then women were randomly sampled from their households rather than from workplaces, which was a strategy to try to maximize variation in job type. There is some like day labor, informal settings of selling goods. We haven't looked at differences by job type, but because there's so much variation, these get to be really small sample sizes once you disaggregate that way.
All right, thanks everyone. Thank you to the presenters today. Thank you to the audience. That's it for the session.
Pretty. Yeah.
So like the whole.
There's definitely that they got workplace well-being, what we do. Additionally, like validation, not adjustment for other modalities. What you're saying here is what you're looking here. When we did this, we used a score. And yeah.
Okay.
Yeah, that was, yeah, I think I was not arguing that like.
Yeah.
Yeah, yeah.
But I. And then it's hard to do. You guys need to activate your.
I was like skipping over it because, yeah.
That was it. I like had a much longer.
Like I didn't think unlike this challenge, but
Do those more factors, like, plan, like, if that was, you would have expected them?
yeah, I guess the like, they are, they're on. I think the challenge is that it is measuring their cost of creation of age. I think the difference
And so we're, like, I'm here.
the other day, it's just like, there were 20 minutes, and I'm gonna remind them there. They had 90. But then they gone through their. Yeah. So, it's 28. No, and our student was a dad part of this. You guys got the student because being hard for her. Yeah, like if you're not having to lie in your like push not be done. There's probably for you to try this. Yeah, less than 8% would use reusable at all, like we had a screening question. But then, even within that, we don't know a lot. Yeah. And not applicable to washing. Yeah. Everyone is every agriculture right out in this area.